So we're just going to do questions and we'll jump right ahead. So question 1, according to cognitive theory, which of the following types of maladaptive schemas are generally more prominent in depressive disorders? Catastrophic thinking, thought action fusion, overestimation of threats, negative evaluation of self, or inflated sense of responsibility. Cool. One full and there we go. Oh shoot. I got it. All right. All right. So everyone got the right answer. It is self negative evaluations of self. So the explanation for that is catastrophic thinking is a cognitive distortion that prompts people to jump to the worst possible conclusion. It's usually with limited information or objective reason to despair, and which kind of points to anxiety. Thought action fusion is the tendency for individuals to assume that certain thoughts either imply the immortality of their likelihood of catastrophic events, and that points more to OCD. Overestimation of threats is associated with exaggeration of their importance and attempts at over control. That's more towards anxiety as well. And then the negative self-evaluation, there's 3 facets of such evaluation, which are shame proneness, self-criticism, and everyone got right is depression. And then inflated sense of responsibility is when you feel like you have more control over the world than you actually do, and you might feel responsible for things that you can't realistically control, like how people behave or feel, natural causes, accidents, and more. And again, this points more towards OCD. So yay, everybody got that right. The next question is, a patient presents with 3 weeks insomnia and loss. Family members report that patients have been despondent, refuses to engage in usual enjoyable activities, and spends most of his, although the patient feels the mood improves somewhat in the evenings, family reports that patient has no interest or pleasure in engaging with his grandchildren when they visit for dinner. On an interview, the patient reports guilty ruminationlessness. A diet by following DSM specifiers should be applied to the diagnosis. The answer choices are anxious distress, atypical features, catatonic features, melancholic features, or mood congruent psychotic feature. All right. So we're gonna share the results. 94% of the right answer, and that is melancholic features. So when you look at, so you have to have 2, which includes restless because of worry, fear that something awful might lose control of herself. So it doesn't really seem with anxious distress. So that was not the right answer. The second is atypical features, which some of you did pick, which is two or more of the following symptoms. Appetite, which he actually had less. Hyperinsomnia, latent paralysis, have, which is heavy laden feelings in arms or legs, and long standing patterns of interpersonal rejection. It's not limited to the mood disturbance that results in significant social or occupational impairment. Catatonic features, so it's basically has to be dominated by two of the following. So motor immobility as evidenced by catalepsy, which includes waxy flexibility or stupor. Excessive motor activity, which is like just purposeless movements, not influenced by external stimuli. Extreme negativism. So there's motiveless resistance to all instruction or maintenance of a rigid posture against all attempts to be moved, or mutism. And then there's voluntary movement as evidenced by posturing or being in bizarre postures. There's stereotype movements. Repeats after you, or echopraxia, where they repeat the movements that you do. Now, the right answer was melancholic features, which is either of the following occurring during the most severe period of current episode, which is of pleasure in almost or all activities, which he had, and a lack of reactivity to usual pleasurable stimuli, which he also had, and three of the more following: depressed mood, first in the morning, early morning awakenings, marked psychomotor retardation or agitation, significant anorexia or weight loss, and excessive or inappropriate guilt. Now that patient, almost all of these secondary symptoms. And then you also have, in last, mood congruent psychotic features, which are delusions or hallucinations whose content is entirely consistent with the typical depressive themes of personal inadequacy, guilt, disease, nihilism, or deserved punishment. All right, so we'll move on to question number 3. Which of the following is a finding from studies of neuroimmune mechanisms of depression? Answer choices are: cytokines do not cross the blood-brain barrier, pro-inflammatory cytokines are often elevated, decreased number of neutrophils are present, anti-inflammatory agents are ineffective treatment, and last, there is no evidence that antidepressants reduce inflammation. All right, so we're gonna end the poll right there. So a lot of you got it right. The answer is pro-inflammatory cytokines are often elevated. So there is correlational evidence that patients who suffer from depressions have elevated circulating levels of pro-inflammatory cytokines such as tumor necrosis factor alpha, interleukin 1 beta, and interleukin 6. Patients have elevated levels of leukocytes, which may be the source of these increased inflammatory cytokines. And not surprisingly, but a recent study in humans provided the first evidence that peripheral inflammation actually predates the occurrence of depression, as children with higher circulating levels of IL-6 were at almost 10% greater risk of developing MDD by the age of 18 than the general population or children with low levels of IL-6, which was interesting. Next question. An 80-year-old patient with major depressive disorder is admitted to the internal medicine service for failure to thrive. The patient reports months of depression and anhedonia, spending all day in bed and sleeping up to 15 hours per day. For the last 3 weeks, the patient has been refusing nearly all food, resulting in a 20-pound weight loss. Patient appears to grimace and often repeats what others say. The patient has been consistently taking mirtazapine 45 milligrams nightly, following unsuccessful courses of sertraline and fluoxetine. Which of the following is the next best step in treatment? So it's either switch to duloxetine, increase mirtazapine dose, start ECT therapy, add olanzapine oral dissolving tablet, or refer to cognitive behavioral therapist.
Yeah, really easy too. How do you know?
It's a really old person
Appetite.
who's not eating,
Appetite,
losing
yeah,
weight.
appetite is definitely the thing.
All right, so we're just gonna end the poll, and everybody got it right. The answer is ECT. So ECT, this patient was admitted for failure to thrive because his depression was so bad, and he exhibits signs and symptoms of catatonia, such as, he was grimacing, he showed some echolalia, and catatonia is a medical and psychiatric emergency, which is an indication for ECT since it's the best course of treatment. And it also has the highest rate of response and remission of any antidepressant therapy at 70-80%. There are some contraindications to ECT that you should be aware of. So if you've had an MI or CBA within the last 3 months, intracerebral tumor, elevated ICP, cerebral aneurysm, AVM, or pheochromocytoma. All right. The next question we have is, the use of esketamine for treatment-resistant depression must meet which of the following requirements? Continued regular psychotherapy, documented absence of a seizure disorder, discontinuation of antipsychotic treatment, evidence of positive response to ECT in the past, or concomitant use of a conventional antidepressant. All right. So 75% of you got that right. The answer is concomitant use of a conventional antidepressant. So for esketamine, it is approved for treatment of resistant depression, and you have to meet the following criteria, which is that an individual has to be 18 years or older, individuals have been diagnosed with moderate to severe major depressive disorder. Individual has had an inadequate response to the maximum tolerated dose of 2 antidepressant therapies during the current major depressive episode, as defined by less than 50% reduction in the severity using a standard rating scale that reliably measures depressive symptoms, so like a PHQ-9. And this was the answer. Individuals will use ketamine in addition to an antidepressant therapy. So next question. Which of the following brain regions is most commonly targeted with rTMS to treat major depressive disorder? Let's see. Hold on, sorry. I started. Oh, where did it go? Oh my gosh. Sorry, 1 second. I don't know where my phone is. Okay. Where's the next question? All right, sorry about that. Did you launch it? Did you launch it? I can't see it, that's why. Okay. So 92% of all of you got that right. The answer is dorsolateral prefrontal cortex. So specifically, the left dorsolateral prefrontal cortex has been found to be underactive in patients with depression. So usually for TMS, you start unilateral, then you move on to bilateral if there's no response to the unilateral. So the dorsolateral prefrontal cortex has deep connections to the areas of the brain that regulates mood, including the insula, anterior cingulate, and the amygdala. All right. So for the next question, it is a 32-year-old with history of depression, obesity, and asthma has a partial response in her depressive symptoms with the maximum dose of Lexapro. Addition of which of the following medications would be the most appropriate next step? Lithium, modafinil, phenazine, gabapentin, or olanzapine. All right, so most of you got that right. The answer is lithium. So lithium reduces excitatory dopamine and glutamate, but increases inhibitory GABA neurotransmission. It is one of the most useful adjunctive agents to augment treatment for resistant unipolar depression, and it also reduces the risk of suicide. Interestingly, in a double-blinded study in patients with asthma, it has shown an improvement in airway responsiveness. So it can tackle the depression and some of her asthma symptoms. So that would probably be the best mode of treatment for her. Modafinil, shout out to Ryan, inhibits uptake of dopamine by binding to dopamine reuptake pump, which leads to increase in extracellular dopamine. It also activates glutamatergic circuits while inhibiting GABA, which promotes wakefulness. It's sometimes used as an adjunctive treatment to antidepressants, but is usually to target sleepiness and fatigue in MDD. With the patient, it doesn't really kind of talk about she has trouble with sleep, but a lot of patients with depression do. But once we target their depressive episodes, we hope that the sleep improves. So we would go towards lithium before the adenofil. And then phenazine is a non-selective monoamine oxidase inhibitor, which is used to treat depression and anxiety. However, the side effects make it less desirable. As many MOIs, you can't eat foods with high tyramine content, and it can also cause significant weight gain and is contraindicated with asthma inhalers. And the patient was already obese and has asthma, which probably she uses inhalants, so that's not the great choice. Gabapentin, its primary mode of action appears to be at the auxiliary, whatever that is, a subunit of voltage-gated calcium channels. It's not really used for depression. It's used more off-label to augment for anxiety and alcohol use disorder. There are concerns for respiratory depression. However, with this patient, they are struggling with depressive symptoms, not so much anxiety, so that wouldn't be the great next step. Olanzapine, it's an antagonism at the dopamine and serotonin receptors at low doses. It's a great medication option for augmenting mood and also with anxiety. However, one of the big side effects with it is weight gain, and this patient is already obese, so we don't want to start her on that medication. So lithium, at the end of the day, is the next best step. Okay. Next question. A patient with a bipolar type 2 who has been stable for several years on lamotrigine 150 milligrams daily presents to her psychiatrist at 16 weeks gestation with a reoccurrence of mood symptoms. Which is the most likely explanation for this reoccurrence? The answer choices are increased volume of distribution, lack of adherence to medications, interaction between estradiol and UGT1A4, effects of progesterone on glomerular filtration rate, or altercation in the metabolism through cytochrome P450 enzymes. Okay, so all of you got it right. The answer is interaction between estradiol and UGT1A4. Now, 17B estradiol, also known as E2, is increased in pregnancy up to 100-fold in some cases. E2 upregulates expression of UDP, UGT1A4, which is the main enzyme responsible for the elimination of lamotrigine. So the increase in UGT1A4 causes accelerated elimination of lamotrigine, causing the reoccurrence of mood symptoms. Okay. Question 9. Which of the following was a finding reported in the NIMH-funded sequence treatment alternatives to relieve depression study? Subjects treated by psychiatrists were provided with quicker relief from their depressive symptoms. The primary outcome was the response rate to SSRIs. Fewer than a third of subjects remitted when treated with the first SSRI. Pharmacologic intervention along with psychotherapy was found to be the best treatment for depression. Okay, so in order to answer this question right, we have to know what study they're referring to. And it's actually the STAR-D trials. So the STAR-D trial was an open label, multi-center, semi-randomized controlled study with 4 subsequential levels. Inclusion criteria included 18 to 75-year-olds who fit the criteria for DSM for MDD with psychotic features. Follow-up was around 16 to 24 months, depending on their remission rate, with each level follow-up being 12 to 14 weeks. So as you can see to the right, level 1 is showed that 33% remitted using Celexa 40 milligrams. So the right answer was fewer than a third of subjects remitted when treated with the first SSRI. Now, if you look at level 2, you had either switch to Wellbutrin, sertraline, or venlafaxine or Effexor, and with that, the remission rate was 25%, or they augmented the Celexa with Wellbutrin or Buspar, and the remission rate was 30%. And then level 3, they augmented with either T3 or lithium. And then level 4, they switched to one of those medications. So the primary finding was that all agents were equivalent, including augmentation and switching strategies. And then secondary findings was change of remission actually decreased with each subsequent drug levels, with a drop after level 2. So you can see that from the chart. And then also rate of relapse also increased for those who went through more levels. But the overall finding was that 60% of participants did obtain remission. And now for the last question. 45-year-old male patient presents for first outpatient visit with new onset depressive symptoms accompanied by excessive daytime fatigue and hypersomnia. Patient denies any past medical history and does not take any medications. Vitals include blood pressure at 154/90, heart rate at 90, respiratory rate at 18, and BMI at 30. Which of the following is the which is the most appropriate next step? Start patient on SSRI, obtain hemoglobin A1C and lipid panel, EEG, start patient on Adderall, or polysomnography.
Polysomnography. Actually, that's just my random.
All right. So most of you got that right. The answer is polysomnography. So it is important to rule out any medical causes for depressive symptoms. And some of the most common medical causes include OSA. With this patient, they had excessive daytime fatigue and hypersomnia, which are some clinical clues. Also, his blood pressure was a little elevated and he has a BMI of 30, pointing to him being obese. Also, sometimes they'll throw out the neck circumference. So if a male has a neck circumference of greater than 17 inches or a female with greater than 16 inches, that all points to obstructive sleep apnea. Other things you want to look out for is a thyroid disease like hypothyroidism, neurological conditions such as CVA, MS, Parkinson's, and Alzheimer's, head injuries, hormonal changes like during pregnancy, vitamin deficiencies such as vitamin D deficiency, chronic pain, cancer, and also use of some medications. Most commonly, we know the use of steroids can affect your mentation. Also, there's a correlation between depression and beta blockers. and also long-term opioid use and can actually cause depressive episodes because the thought is the longer you use the opioids because of its suppression, norepinephrine actually increases at some point, causing inner restlessness and anxiety, which then can lead to a depressive episode. So just to keep that in mind. And now I'm going to hand it over to Dr. Tampton.
Give us like 2 minutes. Okay, everyone. I'm going to be presenting on geriatric psychiatry. Give me 1 second. Okay, can everyone see this? Okay. So, like I said, I'm presenting geriatric psychiatry. It's going to be a very similar format as Pooja's. So we're going to do some questions and answers. So first question. 69-year-old female presents with progressive behavioral changes and rudeness, interrupting conversations, watching excessive TV, eating large meals despite not actually being hungry, and she has a stooped posture with a slow and shuffled gait. What is most commonly associated with her disease process? Oh, this is the wrong question. Sorry, that was the wrong. I got it. Okay, sorry. There it is. Okay, so this was a relatively hard question. So the correct answer is actually C, intraneural tau deposits. So this case is actually describing frontotemporal dementia. So here I just have a quick summary. So frontotemporal dementia and Alzheimer's are both pretty common dementias they like to ask about on PRITE. So frontotemporal dementia refers to a group of disorders that occur due to damage in the frontal and temporal lobes. I think kind of the way that we've all learned it probably in med school and for step exams was the behavioral variant, which is affecting predominantly the frontal lobe. So you'll see more of the behavioral changes, but there's also actually another variant called the primary progressive aphasic variant, which affects more temporal lobe and more language skills. But common symptoms regardless of frontotemporal dementia. So I bolded the ones that we saw in that last case. So there's the behavioral changes, the repetitive behavior such as watching TV, and the hyperphagia, like the eating, even though she's not hungry. Kind of the red herring of that question is the stooped gait with the shuffling posture, but you can actually see that in frontotemporal as well as Parkinson's. So it was kind of a hard question. But frontal temporal is a tauopathy, so that's why you're going to see the increased intraneural tau deposits. Next question. An autopsy is performed on a 75-year-old male who has progressive cognitive decline prior to his death. The images on his left, so the one or on the left marked as A, D, and G, are from his patient or this patient, while the images on the right, the C, F, and I, are from a health control. What disease did this patient suffer from? Okay, so most of you guys got this one right. So the answer is Alzheimer's disease. So the arrow you can see is pointing to neurofibrillary tangles, which are abnormal accumulations of hyperphosphorylated tau proteins. So tauopathies, Alzheimer's and frontotemporal, are both examples of that. And like I said, these are very commonly asked question or topics on PRITE. So Alzheimer's is a progressive neurodegenerative disease. It's the most common form of dementia in adults older than 65 years of age. Common symptoms, I mean, we all know what Alzheimer's is, so I won't go over all of those, but some pearls and important information you guys should all know for PRITE. So histological pearls are going to be what I just showed you, the neurofibrillary tangles, as well as neuritic plaques. And then some other information that I just pulled these from other questions on previous PRITEs. Earliest evidence of cell loss is seen in the entorhinal cortex. You'll see temporoparietal hypoperfusion in early stages of the disease, and you'll see a disproportionate neuronal loss in the CA1 segment of the hippocampus as compared to controls. Next question. So we have a patient also with Alzheimer's disease who presents to her PCP along with her daughter. Patient and her daughter endorse mild memory impairment. She has no medical nor psychiatric comorbidities. What is the next best course of action? Okay, so the correct answer is A. Most of you guys got that correct. I'll talk about that right after we answer this next question, though, because these are kind of related. So previous patient was started on donepezil, which is an anticholinesterase or a cholinesterase inhibitor, which she tolerates well. 5 years later, dementia has progressed. She's now presenting with significant agitation, lability, and appetite disruption. Medical workup is unrevealing. What would you add to the donepezil? Okay, so most people got that right. The correct answer is memantine. So let me just kind of go over this topic. So these are medications for Alzheimer's. The first three, donepezil, galantamine, and rivastigmine, are all cholinesterase inhibitors, and memantine is an NMDA receptor or agonist. Or it says agonist, but it's an antagonist. So indications, you'll see that donepezil is used for mild to severe galantamine and rivastigmine are mild to moderate, and memantine is moderate to severe, and the dosing for all of these are slightly different. So all three of the cholinesterase inhibitors have relative similar efficacy and side effect profile. The most common side effects we're going to see are GI disturbances, but you can also see dizziness and bradycardia. Donepezil is typically used first line of the three of them. There's kind of a lot of reasons for this. One, it has the easiest dosing. It's once a day dosing from the beginning, and it was the first of all these medications to go generic. So that probably just relates to why it was used first. Rivastigmine is a little bit unique compared to the other two, however, so it inhibits both acetylcholinesterase and butyrylcholinesterase. There's kind of conflicting information out there about how relevant that is, but there is some emerging research that it's possible that butyrylcholinesterase plays more of a role in Alzheimer's than we previously believed. Rivastigmine is also not hepatically metabolized, so there's limited drug interactions compared to the other two medications. And although all of these are used off-label for other types of dementia, rivastigmine is the only one that's FDA approved also for Parkinson's dementia. So that's just kind of a summary of these. And then, like for the other question, the memantine is typically used for when the dementia becomes moderate to severe. So it's when someone has already started on donepezil, it's very common to later on as the disease progresses to add on memantine as it has a different mechanism of action. So next question, we have an 80-year-old patient with bipolar disorder who's been stable on lithium for several years. Recently, the physician prescribed a new medication. Patient now has tremulousness, dystonia, hyperreflexia, ataxia, and confusion. Which of the following medications might be contributing to the patient's presentation? I don't know why answer C is there. Sorry, I think I might have taken this from a different question. So most of you guys have gotten that right. The answer is thiazides. So the reason for this is once someone starts a thiazide, it's a diuretic, obviously. So it results in hyponatremia, which results in proximal tubular reabsorption of sodium, but also lithium. So it can cause lithium toxicity. This is a very commonly asked question. Thiazides can result in lithium toxicity. Next, we have an 87-year-old patient with a history of schizoaffective disorder who takes several psychotropic medications. He presents to the ED with symptoms of confusion, blurred vision, and tachycardia. His symptoms are likely related to toxicity of which of the following medications? Okay, so the correct answer here is cogentin. So all of the symptoms he's exhibiting, the confusion, blurred vision, and tachycardia, are all symptoms of anticholinergic toxicity. Cogentin or benztropine is an anticholinergic, and geriatric patients are much more sensitive to anticholinergic medications, and he's 87 years old, so that's why that is the correct answer. Next, the Beers criteria for potentially inappropriate medication use in older adults is a list of guidelines for safely prescribing medications for adults over age 65. Antipsychotic medications are found on this list, and why are they on that list? Okay, so this one is also kind of a tricky question because obviously EPS side effects are more common in older adults. But the reason that antipsychotics are, sorry, there's a very loud truck. But the reason that antipsychotics are not the risk of CVA.
Absolutely.
So we'll see here, there's an increased risk of CVA in all the weeks starting.
Yes, and we have been trying to get him out of the hospital. As you all know, this is an acute care unit. And we try
Auber, I
to
think
have
your
that appropriate
microphone's
disposition for every patient here. And Mr. Pulliam has been with us, has
Okay. Okay, I don't know how to go back to that slide. Okay, I can't go back to that, but the the previous question, so the reason the answer was CVA is that on in I mean, all antipsychotics have a risk of CVA. That risk is with typicals and atypicals, and it's more prevalent in older adults with history of dementia. So anyway, this next question, 70-year-old patient with a history of Parkinson's has developed new onset hallucinations and delusions. Medical workup is unremarkable. Of the following, which is most likely to worsen is underlying Parkinson's? Okay, most of you guys got that correct. The answer is Haldol. So the reason for this is in Parkinson's, if an antipsychotic is needed, atypical antipsychotics are better choices than typicals. So Clozaril and Seroquel actually have the least risk of worsening Parkinson's symptoms. Also, the other answer choice, Nuplazid, is actually medication that was approved specifically to treat Parkinson's disease patients that need an antipsychotic. So that's why the answer is Haldol. Next, we have a 78-year-old patient with a history of dementia and bipolar disorder brought to the ED by his daughter. Daughter reports patient says increased physical and verbal aggression at home towards his new home health nurse. Patient has not been aggressive towards family at all. Patient is unable to explain his behavior. What's the most likely cause? Okay, so the correct answer is elder abuse, actually. And so the reason of that for this, kind of the clue in this question is that the patient has not been aggressive, whatsoever with family. So elder abuse is actually, unfortunately, a very common phenomenon. It affects approximately 15% of older adults. And one of the risk factors for elder abuse is cognitive impairment. So this patient obviously has dementia. And also psychological distress. This patient has a history of bipolar disorder. So it's just very important to remember all geriatric patients need to be assessed for elder abuse. A lot of older adults, there's a lot of shame associated, and so they won't spontaneously offer to you that they are the victim of abuse, but it's important to assess. And there are several interventions possible to prevent mistreatment. Usually those are geared towards caregivers to avoid caregiver burnout. So question 10, we have an 80-year-old man with no psychiatric history who is brought to EPS. I'm sure you guys have seen this before. He's acutely agitated, thrashing in his stretcher, screaming nonsensically. What is the next best step prior to a full medical evaluation? All right, and most of you guys got that correct. The answer is administer IM haloperidol. The reason that that's the correct answer, so B, administering Benadryl. Benadryl is an anticholinergic. We don't really know what's wrong with this guy. He might be delirious, so we should avoid anticholinergics. C is incorrect because he's too agitated to take a PO. D is obviously incorrect because you can perform a MOCA on an acutely agitated person. And then E, calling the nursing home is a good option, but just because he's acutely agitated, which is an emergency, he's thrashing around in his stretcher, we have to give him medication first. So next we have an 80-year-old patient. This is my last question. We have an 80-year-old patient with MDD who has tried SSRIs and SNRIs. Oh, I just showed the answer. Anyway, I'll just talk about it anyway. The patient has not yet tried a TCA, no known history of cardiac disease and EKG. Which medication is most appropriate? So the reason the answer is desipramine is because it's a secondary amine compared to some of the others with less potent anticholinergic side effects. So yeah, that's why that's the answer. And that's all of my presentation. Thank you, guys.
Thank you both for a great presentation.